Okay, good morning from the Barrow Neurological Institute and the Sontag Spine Center in the middle of the Sonora Desert in Arizona. We are very grateful that the Serial Science Foundation, and especially the Texas Vax Institute leaders, Dr. Geyer and Dr. Lieberman and others, we were able to share with you our journal club today. And I'm today with Jay Turner, one of our premier surgeons at the Barrow Neurological Institute, and our fellows, Dr. Farber, Dr. Allen, and Dr. Zhao. So today we have a really good articles to discuss, and we're going to be focused on how to avoid complications on minimal invasive spine surgery. But which is more exciting is that we're gonna go deep in what we think we know the best, which is the minimal invasive lateral access, which we've been spending a lot of time in our careers trying to refine this amazing access to the spine. So we're gonna start getting going first, and our first article is actually a meta-analysis where we're trying to find out the different options to access the spine lateral, specifically the pre-psoas and the trans-psoas approaches, and then a good meta-analysis where we found a really good conclusions and points to discuss and expose to you guys. So Dr. Farber will be opening our journal with this amazing article. Welcome, Dr. Farber.
Thanks, Dr. Uribe. Good morning. Thank you to the Seattle Science Foundation for allowing us to present today. I'm going to pull up our PowerPoint. So, as Dr. Uribe said, our topic today is going to be complications and complication avoidance in minimally invasive surgery. The first paper that we're going to be reviewing is a meta-analysis we published a couple years ago, as he said, comparing pre-psoas and trans-psoas approaches. So, why MIS surgery? Many benefits: decreased blood loss, less pain for the patient, shorter length of stay, fewer infections, less tissue dissection means less muscle denervation and devascularization, with the goal of accomplishing your goals of surgery with the least amount of tissue disruption possible. So specifically, the lateral retroperitoneal approach has many benefits that we believe in, including the ability to perform an extensive discectomy and wide preparation of the end plate for fusion. It allows you to place a large interbody, which spans the entire width of the vertebral body. It allows you to achieve indirect decompression of the neural elements with restoration of disc height via ligament ataxis. It also avoids any disruption of posterior tension bands, or allows you to avoid any previous defects from any posterior surgeries, previous laminectomies, etc. So there's really two main procedures that are done for interbody fusion with this approach. First is lateral lumbar interbody fusion, which is a trans-psoas approach. Proponents of this procedure, tout its ability, the orthogonal plane to the spine to place the interbody. It also allows you to avoid anterior structures like the colon or the major vessels. The alternative approach is the oblique interbody fusion, which is a pre-psoas corridor, with proponents advocating that you can avoid issues retracting or injuring the lumbar plexus and the femoral nerve, which runs through the psoas muscle. So as you see in this figure, via both of these routes, there's a lot of anatomical structures that are adjacent and that are prone to injury, and you have to really be aware to avoid complication. So there's not a lot of good data comparing these surgeries, and and mostly it's retrospective. For many reasons, randomized studies would be very difficult in these procedures. And so the goal of this paper specifically was to compare complication rates in the literature for pre-psoas and trans-psoas lateral retroperitoneal approaches, as well as looking at reported rates of subsidence and pseudoarthrosis. So here's the systematic review. And this is for the pre-psoas papers. So out of an initial 81 records that were identified, you see our criteria here all in English. We only included papers with greater than 10 patients. So, we removed case reports or small case series, had to include specifically complications or radiographic outcomes. For the pre-psoas group, we excluded complications related to L5S1 since this is not routinely performed through a trans-psoas approach. After this review, we ended up with 20 papers included in the complications analysis and 8 in the radiographic analysis. Again, for the trans-psoas studies, out of an initial 254 identified, same inclusion criteria. We actually excluded ACR from these studies. And came up with 39 papers for complications and 19 for radiographic. So here's table 1 from this paper, just kind of showing you the long list of papers that were included. We won't go through all these specifically, but you see there's variable rates in each of these papers of the complications, and it's varied of what was actually reported in each paper. So then looking at the meta-analysis, overall, in the trans-psoas group, there were 4,607 patients included. In the pre-psoas group, 1,874. They had similar age, gender, follow-up time. The mean number of levels per patient was similar. The operative duration was greater in the trans-psoas group. This may be related to longer positioning and setup and monitoring. Estimated blood loss was similar, and hospital length of stay was greater in the pre-psoas group. So here, looking at complication rates, we found, this is really sort of the take-home table from the paper. We found that for nerve-related complications, so that includes transient thigh or groin symptoms, transient hip flexor weakness, or permanent neurologic injury. These were all significantly greater in the trans-psoas group. So you see that for thigh numbness or pain or transient hip flexor weakness, these were both around 20% for trans-psoas studies, and they were 8.7 and 5.7% for pre-psoas. Permanent neurologic deficit was also higher. It was 2.8% for the trans-psoas, but it was also 1% for the pre-psoas studies. Contrarily, the sympathetic plexus injury was much greater for the pre-psoas studies. There were none reported in the trans-psoas papers. And the rate of major vascular injury was 1.8% versus 0.4%, so it was greater in the pre-psoas group. There were no differences between the two approaches for bowel injuries or urological injuries, including kidney or ureter. There's no difference in ileus. The infection rate was higher in the trans-psoas studies, and there was no difference in hematomas. So again, these data are shown here in this forest plot. So for the trans-psoas studies, transient sensory symptoms, transient hip flexor weakness, and permanent motor weakness, as well as infection, were all higher in the trans-psoas group, and the sympathetic injury and major vascular injury were greater in the pre-psoas group. Paper also looked at radiographic outcomes. So the table on the left shows all the papers that were included for this analysis. There was a lot of variable reporting here. So for the analysis of subsidence, there was 5 papers that actually mentioned this for pre-psoas and 13 for trans-psoas. Of those papers, the rates, reported incidences were similar. It was 12.2% in pre-psoas and 13.8% in trans-psoas. We also looked at pseudoarthrosis rates out of 4 and 14 available studies, and again found a similar rate. which was 9.9% for pre-psoas and 7.5% for trans-psoas, just showing the robust fusion rates for either one of these procedures. So limitations of this study, it's a meta-analysis, but it's limited by the studies that were included, and really the majority of these are low quality of evidence. They're mainly retrospective, they're cohort studies or case series. So they're definitely, subject to reporting bias. Also, it doesn't allow us to account for chronological advances. So this meta-analysis was performed from up to 2018. So obviously there's been a lot of advancement in lateral access surgery from its initial description to that time, including, learning curve of surgeons, technological advancements, neuromonitoring, things like that, which we couldn't account for in this study. We also didn't look at specific levels. So, I think it's well described that, approach at L4-5 is going to be riskier than, an approach at L2-3. And we also could not account for variability related to surgical indication or surgeon experience or technical factors, things like retractor time. And then in the radiographic analysis, we could not separate standalone versus lateral plate versus supplemental pedicle screw fixation, which would be important. But the conclusions from this study, so overall, the complication rates for both of these approaches are low. The pre-psoas approach results in significantly fewer nerve-related complications. It's difficult to incorporate changing practice patterns, as I mentioned. Things like the addition of directional triggered EMG have really augmented the trans-psoas approach, and I think have helped decrease nerve-related injury. And that was something that's hard to include in this paper. But it's also important to note that neurological injury was not completely avoided in the pre-psoas approach. That still requires dorsal retraction of the psoas muscle if you're trying to place the inner body in an orthogonal plane. And the studies do show that there still are some neurologic deficits related to that. Sympathetic injury was increased with the pre-psoas approach. There were none reported in the trans-psoas studies. It's possible it's just being underreported. There was a 5 times higher risk of major vascular injury with the pre-psoas approach. In this study, we did not include any papers describing ACR, where the ALL is sectioned, which would likely increase the risk of this for the trans-psoas surgery. There were similar rates of bowel and urological injury, and there are also similar rates of subsidence in pseudoarthrosis. So we decided for the rest of this talk to sort of focus in on a couple of these complications in particular. So Dr. Allen's going to talk about our next paper.
Great. Thank you, Dr. Farber. Thank you,
Allen.
Seattle Science Foundation, for this invitation. The Journal Club has been very instrumental in my own education throughout the years. As Dr. Farber said, I will focus on the femoral nerve injury using a paper from Neurosurgical Review published in 2018 by Dr. Abel, Januszewski, Vivos, and Dr. Uribe. And it is titled Femoral Nerve and Lumbar Plexus Injury After Minimally Invasive Lateral Retroperitoneal Trans-psoas Approach, Electrodiagnostic Prognostic Indicators, and a Roadmap to Recovery. In a brief introduction, as Dr. Farber said, lumbar plexopathy is a well-described complication of lateral lumbar interbody fusion. Especially transient sensory deficit and hip flexion are very common, but the most feared neurological complication after lateral lumbar interbody fusion, or LLIF, is femoral nerve injury, especially at L4-5. But at the time of the completion of the study in 2018, there was a few studies, maybe no studies, that had investigated electrodiagnostics and recovery from lumbar plexopathy, especially femoral nerve injury after LLIF. So the author's objective was to study the temporal correlation of electrodiagnostic changes and nerve root injury, not nerve root injury, nerve injury and recovery after LLIF, and they reviewed the relevant literature in the discussion. This is a retrospective review of a prospectively collected database. It is single center, single surgeon from 2011 to 2016. It's a consecutive case series of patients who underwent LLIF. The inclusion criteria were indication for mechanical instability, spondylolisthesis, degenerative disc disease, adult spinal deformity, adjacent segment failure, and trauma. They excluded oncological and patients who had previous retroperitoneal surgery. So patients who had a neurological deficits were identified. Those who had a severe femoral and or obturator nerve injury underwent electrodiagnostics following the following with the following criteria. At 6 weeks, if the injury had resolved, there was no further electrodiagnostics, but that's the first time point that electrodiagnostics would obtain. And if the weakness persisted, it was repeated at 3 months, 6 months, and 12 months. Severe nerve injury constituted MRC strength of 3 out of 5 or less in femoral and or obturator nerve distribution. The electrodiagnostics used was EMG and nerve conduction study, and they were all analyzed by a neurophysiologist who was blinded to the patient's exam. 230 patients underwent LF during the duration of the study. 6 patients had severe nerve injury, that's 2.6%. 2 patients improved by 6 weeks according to their criteria. These patients did not undergo any electrodiagnostics. This is consistent with neuropraxia, and in the discussion, I will get into the details of what exactly this means. 4 patients had a persistent weakness at 6 weeks. These are the patients who underwent electrodiagnostics. All 4 showed fibrillations and positive waves in the distribution of femoral and or obturator nerve, and that is consistent with axonomesis. Again, I will discuss in detail in discussion what these different types of peripheral nerve injuries are. One of the important contributions of this paper, I think, is to document the extent and timeline of recovery, which allows the surgeon to counsel the patients and have the right expectations. So in this series of the 6 patients, 1 patient had a full recovery to 5 out of 5 in both iliopsoas and quadriceps, and 5 patients had partial recovery to 4 out of 5 of iliopsoas and 3 out of 5 in quadriceps. Timeline of recovery varied between 3 months to more than a year. 2 patients had recovered by 3 months, 2 patients by 11 months, and 1 patient by 13. So those last 3 patients essentially took up to a year after surgery to recover. There's a table in the paper that discusses that discloses the details of the surgery, including what the intervention type was, the excuse me, the immediate post-op exams, electrodiagnostic findings at 6 weeks, 3 months, and at 12 months. I don't get into the details of these different patients, but I summarize it in the previous slide, what the recovery was. Sorry, extent of injury and recovery was. So in the discussion, the different types of injury are discussed. One type is direct. That's when the dilators are passed through the psoas, and especially during the deployment of the shim, there's a possibility that you could easily sever this nerve, the femoral nerve. That could be the direct injury. That is relatively uncommon, but the most common type is indirect. That's when the retraction is deployed, and there could be 2 types, compression or traction. That the difference between compression and traction is just how the force is applied to the nerve. Compression is when force is applied perpendicular to the long axis of the nerve. So if this is a long axis of the femoral nerve, when the retractor is open, if it applies force perpendicular to that long axis, that would be compression. And if it applies force along the long axis of the nerve, that would be traction. The authors also briefly mention the different mechanisms of injury, which is related to the direction, time of retraction, and amount of retraction that is used during surgery that affects the extent of peripheral nerve injury. In the next segment of the paper, there's a discussion of the classic classifications of peripheral nerve injury. The first one is a Sedan classification from 1940s that are the three types that are commonly used: neuropraxia, axonomesis, and neuromesis. Sunderland in the 1990s further subdivided these, especially the axonomesis, to three different types, providing 5 total grades. And the authors have a table that summarizes this very nicely. So on the left, the Sedan classification is essentially 3 types: neuropraxia, axonomesis, and neuromesis. Sunderland's first degree is equivalent to neuropraxia. That is a conduction block with excellent prognosis due to the fact that axons are not disrupted, only the myelin sheath is disrupted. These patients have excellent prognosis, especially at 3 months. The Sunderland's contribution, as I mentioned, is the granular information about the different types of axonomesis that are based on the structures that are disrupted. And these are pathological findings, meaning that they can only be distinguished under microscopic examination by pathologists, not based on electrodiagnostics. So in the second degree, the most favorable type of axonomesis, only the axons is disrupted. These also have a good prognosis. The third degree, the axon is disrupted along with the endoneurium. And in the fourth degree, also the perineurium is disrupted. So essentially, Sunderland's contribution was that the more the microstructure of the nerve is disrupted, the worse the recovery. So the third degree has a better recovery than fourth degree. And the fifth degree is a neuromesis. That is a complete discontinuation of the nerve and all its microstructures. That is the axon, endoneurium, perineurium, and epineurium. These are potential candidates for surgical repair. So in the final segment of the paper, there's a discussion about what to expect in these patients and the timeline. So the patient that wakes up with neurological deficit in the acute phase within 24 hours, the most important thing to do is for the surgeon to rule out any structural reversible causes by obtaining an MRI or a CT scan. At Barrow, we obtain MRI CT scan on all patients, regardless of their neurological status, but certainly it adds urgency if there is a neurological deficit that allows you to identify reversible causes such as misplaced screw, misplaced or migrated cage, and such that could be easily identified and fixed. In the early subacute phase, that's 6 weeks, that's the first time that the electrodiagnostics, EMG nerve conduction studies are obtained. This serves as a baseline. It does not give you much information about the severity of the injury. And the most important prognosticator at this stage is the compound action potentials, that if there are more than 50%, it's a good prognosticator. If less, not so much. At 12 weeks, 3 months, that's when neuropraxia should resolve. If no motor units are present on EMG, or there is no compound action potentials with stimulation, this is the first time you can diagnose a patient with neuromesis, that the nerve is essentially completely severed. The next time point is at 6 months. The authors emphasize the presence of small amplitude and small duration on EMG. And if only proximal SASTs are present, that means that there are no surviving residual motor units available for regeneration, and that constitutes a more severe injury. In the late chronic, at 12 months, about a year, if the SASTs start to progress from more proximal to more distal muscles, that means that degeneration is continuing, and that also means a more severe injury. This is a table that these different electrodiagnostic findings are summarized in more detail, as I discussed it earlier. And they also provide a timeline of what exactly is happening during the up to 2 years after surgery. So in hours after surgery, you will start to see Wallerian degeneration. Days later, novel axonal regrowth starts in the proximal segments of the nerve. Up to 2 weeks, you start to see fibrillation potentials and positive sharp waves in the proximal muscle. And at 4 weeks, it propagates distally. At about 2 months, reinnervation of the muscle fibers begin. At 3 months, that's when you see the resolution of the neuropraxia, where the weakness from the muscle splitting due to approach is resolved. And this process essentially continues up to maybe 2 years after surgery. And that's when the muscle fibers and neuromuscular junctions are no longer viable. And this is important to counsel the patients that you need to continue this process for maybe up to a year to see extent of full recovery. And in the following examples that I will provide, you will see how this could be very profound. This is a patient who underwent an L4-5 lateral lumbar interbody fusion by another surgeon that was referred to Dr. Uribe for a second opinion. This is a few months after surgery. You see that the clear atrophy of the quadriceps on the right side, the side of the approach, and the lines here demonstrate the distribution of sensory changes. I have a couple of videos to show. So this is at 4 months post-op. This is the same time that the patient was seen here. EMG at this time is showing fibrillations and positive waves and SASTs. And as I mentioned earlier, these are signs of axonomesis. So here the patient is asked to hip flex to 90 degrees. This is where the iliacus muscle is activated, not the psoas. It's important to distinguish these two. And he's able to bring it to 90 degrees. This is the side of the approach. On the contralateral side of the approach, you can easily do that past 90 degrees, but he's not able to do that past 90 degrees on G side of the approach. That tells you that the psoas muscle is affected. Now the patient is asked to extend the knee. This quadriceps is full strength on the contralateral side, and he cannot do it on the right side. So it's 0 out of 5. And again, you can appreciate the asymmetry in the muscle in the quadriceps. This here is an adduction of the leg obturator muscle is activated, full strength on the left and 0 out of 5 on the side of the approach. So here patients followed up at 5 months later, 9 months after surgery. So here the patient is able to, for the first time, flex his hips past 90 degrees. So this psoas is starting to recover. Left contralateral is full strength. This is becoming anti-gravity, 4 minus out of 5. Left leg extension is full strength. Here the patient is asked to extend the right leg, activating the quadriceps muscle, but he's not able to. Left leg adduction, full strength. And now the patient is starting to move right leg abduction. Sorry, adduction. So the patient is tracing the sensory deficit in the saphenous nerve, which is a sensory nerve of the femoral nerve, and the operator distribution. So a classic representation of where these nerves provide the sensory coverage of the leg. So if you notice, 14 months after surgery, again, these patients need to be continued to follow to see how much they improve. And you can see the patient continues to have atrophy of the right quadriceps, but this is the first time that he's able to give anti-gravity strength with right extension, much better right leg abduction with obturator nerve, and hip flexion past 90 degrees, which was present in the last follow-up. Sensory deficit is in a similar distribution, but less extensive, also in femoral and obturator nerve distribution. The other example is a patient that we operated on with the L4-5 lateral trans psoas. 48 hours post-op, the patient is examined. Here is the patient is asked to flex his hip, and you can see that he's able to give you effort not past 90 degrees and essentially no right knee extension. Contralateral to the approach, he's full strength. It's tracing where the sensory distribution deficit is. This one is only femoral nerve, or saphenous nerve, I should say, from the femoral nerve. And then 8 weeks post-op, the patient is evaluated in clinic, and oops. At 8 weeks post-op, he's re-examined. So right was the side of the approach, and he's asked to flex his hip, goes past 90 degrees, it's full strength. Asked to extend a knee, is full strength. And the contralateral side of the approach, as expected, remains fully intact. Okay. That brings my paper and the cases to conclusion. I'm going to pass this to Dr. Dow for the third paper.
Thanks, Dr. Allen. Good morning, everyone. My name is James Zoe. Very much appreciate the opportunity to be presenting to you guys today. For the third and final paper, we're going to be looking at a publication that we released out of here earlier this year with Dr. Hiranua, Dr. Walker, myself, Dr. Godzik, Sumya Sagar, Dr. Farber, and Dr. Uribe. And the title of the paper is Predictors of Subsidence After Lateral Lumbar Interbody Fusion. Just to build off of what Dr. Farber and Dr. Allen said, one of the main advantages of lateral lumbar interbody fusion is the ability to place a much larger and taller graft than you would through a posterior only approach. And one of the things that you can do with this is to obtain indirect decompression of the neural elements via ligamentataxis, and this obviates the need sometimes for a posterior approach and can avoid you an additional stage of surgery and the associated risk. Unfortunately, a downside associated with this is that if your graft subsides and you lose height, then that causes you to lose your indirect decompression. And this has been shown to be an independent risk factor for revision surgery. Unfortunately, the risk factors for graft subsidence are not fully understood. And so our objective with this publication was to investigate what factors predispose to subsidence in our own patient population. So this was a retrospective review of a prospectively managed database, 131 consecutive patients for a total of 204 levels performed by a single surgeon were reviewed. All patients underwent a postoperative lumbar CT scan and had standing scoliosis x-rays at 6 weeks, 12 weeks, 6 months, and 12 months postoperatively. And the radiographs at each of the postoperative points were surveyed to identify postoperative subsidence. Notably, we excluded patients who had intraoperative end plate violation. I'll speak more to this later, but the risk factors that were evaluated include age, gender, BMI, the number of levels treated, cage height, cage material, the ratio of the cage area to the inferior end plate area, and for this, surface area data of each implant was obtained from the manufacturer and compared to the patient's own inferior end plate area. Posterior fixation and bone density is measured by L1 Hounsfield units. The results, so initially subsidence was identified at 23 of 204 levels, which puts us at an 11.3% rate, which is very much in line with the previously reported literature. But on secondary review, we found that 11 of these levels had intraoperative end plate violation and immediate subsidence on the postoperative CT scan. And those were excluded as we wanted to investigate the factors that led purely to postoperative settling, not those associated with intraoperative end plate violation. So that left 12 of 204 levels, which is 5.9% to be classified as true subsidence for the purposes of analysis. And all of these cases were observed within 12 weeks of surgery. Here's table 1 from the manuscript. The only notable findings here is the univariate analysis, where that cage material appeared to be protective against subsidence. So titanium, 0% of titanium cages subsided, whereas 8.1% of the peak cages subsided. There was a larger amount of peak cages, 150 as opposed to 55 in the titanium cages, because the titanium cages only began to be used about midway through data collection. And the other factor that was found to be predictive on univariate analysis was the ratio of the implant area to the inferior end plate area. You can see that for patients who subsided, the ratio was 0.34. And for those who did not subside, the ratio was 0.42. And on multivariate analysis, the only factor that appeared to be protective against subsidence was a higher ratio of implant area to inferior end plate area, indicating basically that larger grafts with more end plate contact were less likely to subside. A brief discussion, several discussion points. Overall, the percentage of subsidence cases in this series was low, 5.9%, as compared to historical averages, which range from 10 to 16%. One of the reasons that likely occurred was because the cases of intraoperative end plate violation were excluded. And on the univariate analysis, we found that only the cage material and the lower implant to end plate area ratio were predictive of subsidence. And on multivariate analysis, only the latter of these two were predictive. On the right here, one of the possible explanations for this, I've included pictures of the two types of graft that were used. One is the top one is the titanium graft, and the bottom one is the PEEK graft. And one of the factors that you'll notice is the titanium grafts of the same size have much larger surface areas than the PEEK grafts. And that's one reason why the graft material might have washed out on multivariate analysis. The study has some limitations. It was a retrospective study. The titanium cage was only approved midway through the study period, which meant there were fewer titanium cases to analyze. Due to patient selection factors, there are very few osteopenic or osteoporotic patients included, and that may have led to discounting of the effect of bone density. We only investigated radiographic subsidence in this paper. We did not account for clinical outcomes, and the overall event rate was low. As I said, only 11 cases of subsidence. And so potentially there's a lack of power to detect effects from things like bone density and posterior fixation, which should ostensibly have an effect on rates of subsidence. But in conclusion, I think the overall prevalence of subsidence after LF is low. In this series, the majority of cases occurred within 3 months of surgery. It's possible, based on this data, that a higher ratio of implant area to the inferior end plate area is protective against subsidence. And in this study, there was no clear association between subsidence and posterior fixation or bone density. But it's likely that due to the low event rate, the study was underpowered to investigate for these findings. I'm going to turn it over now to Dr. Farber for the final case.
Yeah, so that paper was looking at postoperative subsidence. We're going to show a case that we did a few weeks ago of a patient who had in-plate violation and how to avoid subsidence when that occurs. So the patient was 75. She had long-standing back pain. She had undergone many conservative treatments. You see she had an interspinous space replaced previously. She had no leg pain or claudication, no bowel or bladder symptoms. Her MRI scan showed multi-level degeneration, multi-level stenosis, L4-5 spondylolisthesis. Here was her CT scan. She had autofusion of the L5S1 segment. Again, shows that interspinous spacer. So for her, our approach was a planned two-stage L2-5 lateral transpsoas approach, followed by percutaneous pedicle screw fixation. And we're going to specifically talk about L4-5, where an in-plate violation occurred intraoperatively. So here's an intraoperative picture showing the cob is coming into the disc space, and you see the poor bone quality as we progress the cob. You see it violates the in-plate into the vertebral body. So when this occurred, we had to take great care to avoid further, placing our box cutter into this track as well. So we typically use a size 6 box cutter. We used a smaller one in this case to and really made sure that we could easily pass this across the disc space without entering the area of violation. Once we did that, for placement of the interbody itself, we use this long blade, knowing that if you can get the interbody from to span the apophyseal ring where the bone is strongest, it can still hold, and that's the advantage of these very long grafts. So this is the blade that's used to protect while the graft's inserted, and this is what the graft looks like once it's in. And here's the lateral, showing that we were able to maintain the integrity of that implate. Post-op, or here was the final X-rays. The other levels proceeded well, and then post-operatively, the CT scan showing again the implate integrity. Here's a post-op MRI showing the nice indirect decompression, and this is the patient's standing X-rays post-operatively.
Okay, thanks very much, Dr. Farber. This as the everybody here can see it, what we did is first we highlight on the meta-analysis where were the more common complications on the lateral approaches. As you saw, the leading complications on the lateral, transpsoas or prepsoas, the most common complications here are lumbar plexus injuries of subsidence. So that's why we choose the next two papers were actually related to the most frequent complications that were presented by Dr. Farber and Dr. Su and Dr. Allen. And then, which is very interesting, is just to get started the conversation with our friends of Texas Back Institute and Dr. Turner also interacting in here, is that 2 points, that no matter how you approach lateral, even if you're prepsoas, when unfortunately there's a little bit of mislead, you still have neurological complications. So that's why we think that neuromonitoring, it will be very important no matter how you do it, prepsoas or transpsoas. And second, which was very interesting also, is that what we call catastrophic complications, which is vascular and bowel injuries, actually are more frequent on the prepsoas approach. So I just want to go from here. I want Jay Turner to start the discussion and then start interacting with our Texas Back Institute friends. And is any question for our authors? Jay.
Great. Yeah. Thanks, Dr. Uribe. So I think complications are a very important topic, and I think it's important to understand when looking at these types of papers, and that these are really challenging to study. For one, surgeons are inherently biased to underreport their own complications. Two, as was the case with all these papers, these are all retrospective reviews, and identifying complications accurately retrospectively is always very challenging. The second paper, looking at the nerve injuries, was a prospectively collected database where the complications that you're interested in collecting were defined up front. And that's really how these papers, in order to be accurate, need to be set up. So I think we have to assume that there's probably underreporting, particularly for our meta-analysis, underreporting of complications based on the papers that are available for study. And I think it's our responsibility for all of us to really understand our complications. One, for understanding how to improve, but also to have honest discussions with our patients on what they can expect.
Hey, Juan, I have a question. So, the nerve injuries, fortunately, are relatively rare, but, as your fellow had presented, I mean, some of those atrophy was really, really significant. And I know you do neuromonitoring, but I wonder what percentage of those that had the injury had no changes on any of the neuromonitoring, because we find the same thing. We do a lot of anter, at least I do. And sometimes it's rare, we'll see a complete foot drop and the monitoring was totally wrong.
Yeah, that's actually a really good point, Dr. Geyer. And this is actually, want to make sure that this is, after been trying to understand this, unfortunately, but I would say fascinating complication, which is the lumbar plexus injuries and how to avoid it. We find out, and I think all of you guys agree with us, that, for example, the most common modality to monitoring this surgery is the EMG, the trigger EMG. We think that the EMG only helps you to identify where is the locations of the different members of the lumbar plexus, specifically where is the femoral nerve, so you can decide where to put the retractor relation with that. But after that, the EMG has zero value in terms of provide you nerve health or if the nerve get injured. And that's the problem. So it's a misconception because people think that because you find good numbers in your approach, you're protected about the injuries. And that's the classic example, as you mentioned, Dr. Geyer. Sometimes patients come to us, and even physicians, my monitoring was perfect. The patient wake up with not able to extend the leg. And the answer is that one, yes. EMG does not protect you. That's why there is new modalities right now that have been trying to explore a lot, which is the SSEPs and the MEPs, that trying to see that one can give you a little bit of premonition if the nerve get injured, because as you saw in the examples of Dr. Allen, it's a big difference when you have neuropraxia versus when you have axonotomesis of neurotomesis, because the neuropraxia normally heals in 6 weeks. So how can you, if you're having the injuries, how can you stop in the neuropraxia, not on the neurotomesis? So that's a really good point, Dr. Geyer. I don't know any else on the panel wants to say something else.
So Juan, this is Izzy. Great job this morning with all the papers. One of the things that you guys have highlighted and alluded to is that it's really still hard to compare because the complication profile of a direct lateral, of an anterior to the psoas, even of an ALIF, they're really different complication profiles. So as surgeons, we have to kind of pick our poison. But the one question that I would put to you guys and maybe the rest of the panelists, if you are working in the lateral position and you do get a vessel injury, a bowel injury, what's the first thing that you do?
Jay.
Yeah, sure. So, the visceral injuries are the dreaded complication. Typically I think each is managed a little bit differently. I think the vessel injury is a little bit more common than the bowel injuries, and most of the time venous and can be managed just with a little tamponade. Immediately trying to put pressure, weight, and call on one of your vascular surgery colleagues to have in the wings in case the bleeding doesn't stop. Fortunately, I haven't had to deal with a bowel injury. Plenty of bleeding complications, however. I think exploring and repairing would be necessary if you've identified a bowel injury intraoperatively.
Yeah, and
right. And so the point that I want to get to, though, is if you've got a bowel injury, if you've got a vessel injury, you can't control it, you're resorting to a midline laparotomy. So you're essentially taking the patient out of the lateral and down. And as most know, I'm a proponent of ALIF. I do a retroperitoneal approach all the way up and down. I do a few laterals, a few TLIFs, but the vast majority, and it always struck me as kind of interesting how we are addressing or trying to address the complications in the lateral position when the way to really address them is anteriorly to get the exposure to whatever may happen. So why have we really migrated to all these laterals when we know that the bailout is going to be an ALIF type approach?
Yeah, that's a really good point. The interesting thing is that, and that's a very valid question, because you say, why you do this if, a couple of things that we want to mention. One is, the lateral approach, when you stay within the confines, is actually a very reproducible surgery. As Jay mentioned, for example, I can have vascular injury next week or a bowel injury next week, but in my own experience, for example, I've done thousands of these cases. I never had these two complications because in my playbook, this is a no-no. It's like when you're doing a lumbar disc, biting the iliac arteries on the front. You know, it's something that, or doing a ACDF, getting the carotid. This is thing that can, in your playbook, my playbook, never can happen. And to be honest, vascular injuries or bowel injuries on the lateral approach, most of the time is the surgeon lose control of the case. You go, because the vessels are always more anterior, or the surgeon never studied pre-op images when patient that has a vascular anomaly where the vessels, the bifurcation is early and the vessels run more lateral, or, you know, the bowel injury, for example, is definitely not able to dissect the retroperitoneal, right? Or even more weird, if you're gonna hit with a cup the colon and the colon is getting to your retractor, you know? So obviously, I agree with you. A-leaf is a very safe surgery, but don't forget, you know, when you're doing A-leaves, and 5-1 to me is, A-leaf is nothing better than that, yeah? But when you go 4-5 and 3-4, you know, everybody knows vascular injuries happen and patients can die in the table, and, you know, it's a lot of things can happen. It's not 100% cure. One thing that I want to say, when you have vascular injuries done lateral, that I've been also fascinated with this, you know, trying to see how can you prevent these catastrophic complications. If you look, when robotic surgeons on the abdomen do this procedure, when they had the vascular injury, we're talking about OBGYNs and GU, the first thing that they do is they park the arm of the robot on the vessel that is injured, and they make compression for a long time. And most of those injuries on the vessels, actually, they can handle by pressure. And last week, I wanted to see one of our fellows chime in. We have a near death event, I mean, near catastrophic event. I was doing a lateral somehow, and at the time of putting the cage, significant blood came out of the retractor. Obviously, it was not a big vessel because we were able to handle it. And I wanted to know if Dr. Farber, can you describe how we handle that event? Because it's important, because if you get panic, what happens sometimes is you call prematurely your access surgeons or your vascular surgeon. They open the patient right away. They start doing, and most of the time, as you know, they start throwing sutures on these vessels, and this become like a very grotesque phenomenon. So in this case, for example, we handle it with pressure, and the patient did very good. And then we do a CTA post-op. But I want Dr. Farber, can you chime on, see how, because it's good for people to learn, and this one was something that was recently. Are you there, Dr. Farber?
Yeah. So, yeah, in that case, we were a normal lateral approach, and after we put the cage in, we saw, you know, pretty significant, what we thought significant bleeding. So, Dr. Uribe immediately held pressure to tampen out the bleeding. I think the first step was, you know, notifying everybody in the OR that there was a potential that there was a vascular injury. And really, it just took time and pressure to give the bleeding time to stop. Made sure that our anesthesiologist was aware. You know, made sure that we were frequently watching the patient's vitals to notice if there were any changes, which there were not. We were able to take an X-ray. You know, we felt during the cage placement that there was no ALL release. There was never a loss of pressure that would be a concern that the cage had migrated anteriorly. We were able to sneak an X-ray while we were holding pressure, which showed that the cage placement was okay. And then after, you know, 10 or 15 minutes, which seemed like 8 hours, the bleeding stopped, and you know, we looked back at the imaging after and saw that there was what was likely a segmental artery that was just sort of had a lower trajectory than normal. That was likely the cause. But really, it was just, you know, not, and throughout the whole course of everything, the patient remained stable, never had any changes, never required any blood products or anything like that. So I think the point was just that, you know, take time, take a deep breath, hold pressure, try to assess the situation. And obviously, we were talking about, you know, having the appropriate teams be available if it was needed. And thankfully, in that case, that, you know, it wasn't necessary.
And more
So
important also, CTA post-op immediately. Make sure that the patient doesn't have a pseudoaneurysm. And this is very important because the fact that you control, you have to make sure that there is not a pseudoaneurysm or something there. So CTA post-op immediately is very important, you know.
Let me just add one thing, Juan.
Yes,
Randy
sir.
Davis made a comment in the chat that he wants me to prove that the complication rate is different. I'm not sure that the complication rate is different. It all depends on who you're going to read, ALIF, lateral,
Yeah.
the complications are going to be there. The point that I wanted to make, and you also alluded to this, is when the surgeon loses control, how do you get control? You go back to an anterior approach. And that's what I want everyone to really understand, that you've got to be prepared, facile, ready for that. And quite frankly, in my hands, my preferred approach is the anterior because I feel that I'm always more controlled. Now, as I said before, I do laterals. I think they're a great tool. But when you want to stay in control for some of the complex deformities, things like that, I still think the ALIF is the way to go, or the retroperitoneal approach is the way to go.
I think it's also important to point out that I think it's a very good point. But you know, with TBI, I'm sure has access to wonderful approach surgeons and vascular surgeons to get you to the anterior spine safely, particularly L4 or 5 and up, where you have vena cava and aorta to contend with. But I think one of the advantages of the lateral approach is in terms of control, you're in control. You don't need a vascular surgeon to mobilize vessels for you. You just need to stay away from them. And with good technique, as Dr. Uribe pointed out, we are pretty successful at staying away from them. It's a rare complication. Whereas with the anterior approach, you have to directly challenge the vessels in order to get the exposure. So it's I think it's a little bit of a different philosophy, but I think your point is well taken. That we need to be proficient in both.
Actually, I like the way that Dr. Uribe said it. He said it's not in his playbook. When we do our anterior exposure with our access surgeons that, are really fantastic. And not that we've seen every complication, but I think that I have over the course of my career. We just are very, very careful and make certain that the fellows, observe the ureter, observe the vessels, and don't make the cuts near the vessel. And we watch them like hawks. In fact, sometimes when it's hard, we don't let the knife in the fellow's hand if we're not sure about it. So again, it's experience. Listen, I'm a big fan of the lateral approach. I think it's been a tremendous advance, especially when you don't have good access to an anterior surgeon. Izzy is one of our access surgeons, but he does his own access surgeon, or access, that is. And I think, this XLIF approach has been fantastic. And, you guys have, continued to master it and refine it and make it better and better. And we all know that Juan is a rock star of the lateral approach.
Yeah, no, thanks very much. So I just want to say that Dr. Farbers, Sao, or Dr. Alan wants to make any remarks. We are running just on the last minute of this, and then if Jay Turner can close for us.
Thanks for the opportunity to speak today.
Hey, Juan, this is Rod. Great presentation, and Jay as well. One of the things I have to say, and I think, Jay, maybe you mentioned it, is, it really hurts us when people aren't honest about their complication rates. And I think early on, people just underreported, injuries and things like that. And I think with any new approach, there's a learning curve. Don't you think, Juan and Jay?
Jay.
Yeah, no question. Yeah, nobody wants to be known for their complications in the literature. I mean, that's your megaphone of talking about what you do, and so it's there's an inherent hesitancy to report it. But I think as academic surgeons, it's our responsibility to let the community know what our true outcomes are, so we can learn from them.
And I think as you mentioned, Rod, it's just fair with our communities and our patients because if we're honest with the complications and we let the community knows and our other surgeons, we just actually improving the outcomes overall, you know. I
Yeah.
always say to our fellows and residents, don't get afraid to have your complications. But also, this is something very important that I want to take this quote from Winston Churchill before we close. Don't forget this. It's okay to be wrong, but you have to be right sometimes, you know. It's okay to be honest and mention all your complications, but listen, you have to get better no matter what, yeah? So,
Exactly.
Thanks very much, guys. And I think this will close the journal for today.
Great job, everybody. Have a good day and a great weekend.
Thank you,
Yes,
guys.
thanks, Powers, and all your
Thank
fellows.
you. Thanks, SSF.
Take care.
Appreciate it.
Great job, guys.
Thank you.